Hi everybody, I am Dr. T. Manigandan, Professor in Oral Medicine and Radiology. I have an experience of around 18 years in Oral Medicine and Radiology. Today I am going to talk about an interesting topic, an examination of an ulcer. The ulcer can be as simple due to a cheek biting or it can be as complex to a cancer, that is a malignant ulcer. In this presentation, we'll go in detail about how to examine an ulcer stage by stage. First, we'll start with the definition of an ulcer. There are various definitions of an ulcer. The simplest definition we can say an ulcer is a break in continuity of the covering epithelium, the skin or the mucous membrane. It is either followed by a molecular death of the surface epithelium or it's due to traumatic removal. Next, we'll move on to the parts of an ulcer. There are 4 parts of an ulcer. First is the margin, second is the edges, third is the floor, and fourth is the base. Then we'll move on to the history of an ulcer, the mode of an onset, how the ulcer starts with, whether it is a traumatic ulcer or it is a spontaneous ulcer. The traumatic ulcer will generally heal in a week's time to 10 days once the trauma has been removed. Thus, once the trauma is not removed, it turns slowly into a chronic ulcer. Like example, a sharp pus which is hurting the tooth, which is hurting the tongue caused by a tooth can even turn into a cancerous ulcer. Depends on the history of an ulcer, we have to assess where the ulcer lies. Whether the ulcer lies in a joint, it takes more time to heal. A history we have to take about how the ulcer started, whether the ulcer started spontaneously or whether the ulcer started and then it has grown into a swelling. So once the ulcer started growing into a swelling, we have to think of a matted tuberculous ulcer, or we have to think of a syphilitic ulcer, or we have to think of any malignant ulcer. Next, we have to think of the malignant ulcer, that's a marginal ulcer, which can start on the scar, from a scar. Next is the duration plays a major role. A simple ulcer, we can divide into acute and we can divide into a chronic. An acute ulcer takes roughly around 7 to 10 days time to heal. Whereas the chronic ulcer, it takes more than 3 to 4 weeks. If it is not healing, we consider this as a chronic ulcer. Generally an inflammatory ulcers comes under acute. Whereas the tuberculous ulcers goes into a chronic ulcer. Syphilitic ulcers or go into a chronic ulcer. The malignant ulcers like epithelioma go into a chronic ulcers. The next part we have to see is a pain. Whether the ulcer is associated with a pain or it doesn't have a pain associated with pain. Generally the acute ulcers are caused due to inflammation or even due to burn will be painful ulcers. When the ulcer you say it is painless, we have to be more alarming. So you have to think whether it is your tuberculous ulcer can be slightly painful, your syphilitic ulcers can be less painful, and your ulcers due to a basal cell carcinoma or a squamous cell carcinoma are painless. It will never pain. So depends on the ulcer, depend on the history, the pain duration plays a major role. Then we'll move on to the discharge. We have to ask the patient whether did you come across any discharge. The discharge can be even any discharge. It can be a serous discharge, it can be a purulent discharge, or it can be a bloody discharge. Every discharge will tell you what type of an ulcer we are going to see inside. Next, associated diseases. The ulcer can be associated with various systemic diseases like diabetes. It can be associated with syphilitic ulcers. It can be associated with your nephritis, or it can be associated with tuberculosis. So every ulcer we have to think not only an ulcer as in a common, we have to see why this ulcer is happening, what is the background of an ulcer. So we have to move on next to the physical examination. The physical examination of an ulcer, we should see a patient as a whole, not only an ulcer as a part. So ulcer may be a part of an examination, but a patient should be examined from head to toe. The patient can be anemic. He can get an ulcer. A patient can have a malnutrition. A malnutrition can causes an ulcer. The patient can have atherosclerosis, which can lead to ulcer, or a patient can have a syphilis, or a patient can even have a tuberculosis. Every ulcer, every systemic condition will tell you what is lying behind. With this, we will move on to the local examination. For any local examination, like you all know how to start with number, site, size, shape, extent. The same thing we are going to follow here. The local examination first is a size and shape. What is the size and shape is going to tell us. The shape, a tuberculous ulcer will always be oval in shape to start with. Once it coalesces with each other, it forms a crescentic borders. Next, we will go into a syphilitic ulcer. The syphilitic ulcers are circular in nature or a semilunar in shape. So, once they coalesce and they forms into a serpiginous ulcer. The varicose ulcer, generally they are oval in shape, vertically oval in shape. A carcinomatous ulcer can always be irregular in shape and size. The size and shape of an ulcer plays a major role in the diagnosis and in the healing process. Depending on the size, we know how much time it takes to heal. If the ulcer is going to be big, definitely it's going to take more time to heal. So how to measure the size of an ulcer? Generally, we can take a gauze piece and put it on the ulcer and measure the dimensions, vertical dimension and horizontal dimension, and record it. So once we progress with the patient, we know whether the ulcer is a healing ulcer or it is a non-healing ulcer. Next is in local examination, number plays a significant role because a solitary ulcers, you have a different set of diagnosis. Multiple ulcers, you have a different set of diagnosis. In solitary ulcers, you get fungal infections in the oral cavity. They are always solitary in nature. You get tuberculosis, you get gummatous ulcer and syphilis. They are all solitary. Varicose ulcers are solitary and chancres in syphilis are solitary in number. Multiple ulcers are common in your aphthous stomatitis, and even in herpes you get multiple ulcers. Next, we will move on to the position of the ulcer. Where the ulcer lies will give you a clue to the diagnosis. There are different type of ulcer lies in different position, different parts of a body. In fact, we can say a rodent ulcer will always be in the upper part of the face, that is above the line which is joining the ala of the nose to the lobule of the ear. It is more towards the inner canthus of the eye. So that is the area where you get a rodent ulcer. Next is a tuberculous ulcer. Tuberculous ulcers, you get to see where the nodes are present. Very commonly you get to see in axillary region, you get to see in groin region or in the neck region, in anterior and posterior triangle. Next is a lupus vulgaris, that is a form of tuberculosis where you get to see in your skin. Very commonly you get to see in fingers, you get to see your tuberculous vulgaris on the face and hands. Your Hunterian chancre in syphilis are very commonly seen in case of your area where it has been exposed, a groin region. A gummatous ulcer are always seen in a subcutaneous plane where the bone lies behind. Mainly we can see in tibia, we can see in skull region. Then perforating ulcers. The perforating ulcers are otherwise called as tropic ulcer, where we commonly seen in a weight bearing joint, mainly on the heel of the foot or the ball of the foot. The last comes with the malignant ulcer, which can be seen in any part of a body. Very particularly in the oral cavity, we can see in the tongue, we can see on the face, we can see in the lips, you can see in the breast, and you can see in the anal region. Next, we will move on to the edge of an ulcer. The edges will tell a story. What exactly you are going to see. Whether you are going to see a healing ulcer, whether you are going to see a non-healing ulcer. What is the edge? The area which connects the margin to the floor is called as an edge. So, an edge can be a sloping. We will have a different type of edges. We will come across it later. These are the different types of an edges of an ulcer. The first type is an undermined edge, very commonly seen in tuberculosis, where there is a destruction takes place in the subcutaneous plane whereas the overhanging skin is fragile and it is loose. The next is a punched out ulcer. What do you understand by punched out? It is taking a punch and take a punch and do a deep cut. That is called as a punched out ulcer. So exactly you will see a vertical cut on the epithelium. So that is very commonly seen in case of your chancre. The next is a sloping edge where you see in a healing type of an ulcer, where the base is from the margin you can see a slope. The slope is lying to the floor. Next is a raised and pearly white ulcer. That is where you get to see the rodent ulcer. The center part will become necrose and the peripheral part will become beaded. The last type of edges, raised and everted edges, are very commonly seen in case of your squamous cell carcinoma, where there will be an overgrowth of the cancerous cells. It will be flowing over the normal epithelium, gives rise to a raised and slopy edges. Next is the floor of an ulcer. What do you see on the floor is the floor. What do you see on the ulcer is the floor of an ulcer. Generally, the floor of an ulcer will be covered with the red granulation tissues in case of a healing ulcers, and a pale granulation tissue you can see in a slowly healing ulcer. Whereas when you get to see a washed leathery slough in the floor, that is, you can think of your syphilitic ulcer. When you get to see a blackish area on the floor of ulcer, we can think of a malignant melanoma. In a tropic ulcer, the floor of ulcer will be the bone. So that is a deep perforating ulcer. So the floor where what lies on the floor makes it a clue to a diagnosis. Then at a discharge. A healing ulcer will have a very scanty discharge. Whereas in case of your inflamed ulcer, we have a purulent discharge. And in a serosanguous discharge can be seen in case of your tuberculous ulcer. Sometimes, very rarely, we get to see a greenish discharge due to a bacterial pyocyanin. And then you can, it is best to take a swab and do a swab culture test to elicit what discharge is giving us, what bacterial. We can do a cell culture and see what bacteria we are getting in it. Next is the surrounding structure. Now we had seen about the ulcer. Now we will move on to the surrounding structure. How the surrounding skin is over there, whether it is stretched, whether it is glossy, whether it is edematous. That gives a clue to it is an inflammatory ulcer. In case of your surrounding structure, in case of a varicose veins, we get to see an eczematous ulcer and you get to see pigmentation. A scar and wrinkling of the surface can be very commonly seen in case of a tuberculous ulcer. With this, we have finished with your inspection. What inspection say, what we are going to see, what we are going to ask the patient. That is history. What we are going to see the inspection. With this, we'll move on to the palpation. What is a palpation? You put the finger and see what you had inspected is right or not. That is a palpation. The first thing, once you put the finger on the ulcer, the patient is going to shout, ah, that is a tenderness. Is it a tender ulcer or a non-tender ulcer? The tenderness gives a clue, okay, whether the ulcer is going to be painful or a painless. If it is a painful, excellent, it's an acute healing ulcer. That is an inflammatory origin. If it is a chronic ulcer, like tuberculous ulcer, as I told you before, it's going to be slightly tender. The varicose ulcer from varicose veins can be slightly tender or never tender. Or neoplastic ulcer will never be tender. So it depends upon the amount of pain we can elucidate what type of ulcer we are going to see. Next is edge and margin. As I told you, what is a margin? The margin which connects the junction between the normal epithelium and the ulcer. What is the edge? The edge connects the margin to the floor of the mouth. So the edge gives the activity, shows the activity of the ulcer. So when you palpate the edge, you're going to see an induration. What is an induration? Some sort of a surface hardness. It is going to be slightly hard in case of a chronic ulcer. It's going to be really hard. Then you have to think of it's a malignant ulcer. So sometimes a chronic ulcer like a gummatous ulcer can be slightly hard. But it will be very hard in case of your malignant ulcer. Next, we'll move on to the base of an ulcer. How to see the base of an ulcer? You have to pick the ulcer with your index finger and your thumb. If you are able to pick the ulcer, you will know. You are able to lift the ulcer where the floor lies, the base lies. So with this, we can see an induration, hardness, everything in where when it is being fixed to the deeper structure. Next, we go to the bleeding. So once you touch the ulcer, it's going to bleed. More likely, a malignant ulceration will have a bleeding. Next is relation to the deeper tissue. As I told already, the gummatous ulcer will be on a subcutaneous, over the subcutaneous bone like tibia or a sternum. It is often fixed to the underlying structure. The malignant ulcers are always fixed when it is infiltrate deeper. They are always fixed to the underlying structure. Next is the surrounding skin. Once you palpate, once you touch the surrounding skin, the first thing what you're going to look at is your temperature, whether the temperature is raised or not. The temperature gives a clue. It's going to be an acute inflammation. The temperature is always going to be raised. And is it tender? It's going to be an acute inflammation. And then we can, whether the surrounding structure are able to, we can mobilize the surrounding structure. If the surrounding skin is moving, that means there is no deeper infiltrate. If the surrounding structure skin is not moving, that means there is a deeper infiltration has already taken place in case of your malignancy. And then we have to see the nerve examination of the surrounding structure, whether the peripheral nerve supply to the surrounding structure is fine or not. With this, we were finished with the inspection. We are finished with the palpation. Next, what is closely associated with your ulcer is your lymph nodes. Any sort of ulcer, the first thing you have to check the regional lymph nodes. Being a dentist, the very common lymph node, what we are going to check is your submandibular lymph node, then the submental lymph nodes. That is the first level of examination. Then we will move on to a neck lymph nodes. So what does lymph node have to tell? So any sort of a lymph node examination, normally the lymph nodes are never palpable. If there is a lymph node is going to palpate, that means the lymph node size is enlarged. It is going to be tender in case of an acute inflammation. But sometimes the lymph node can be soft. It can be matted. That means a matting in the sense collusion of lymph nodes together. In case of your tuberculosis, you get to see a soft and matted lymph nodes. In Hunterian chancre, in case of syphilis, you get to see a firm lymph nodes, that is shorty lymph nodes you get to see. And then the last is the malignant lymph nodes, where it fixed to the underlying structures, and it will be a stony hard or a bony hard in consistency. So the consistency of a lymph node, if it is firm, it's going to be inflammatory. If it is going to be a soft, it is going to be a tuberculous. It is going to be a stony hard or a bony hard, it's going to be a malignancy. So the consistency of a lymph node will tell you what ulceration lies above. Next is the vascular insufficiency you have to check. If you get to see an ulcer on a lower part of a leg, you have to always examine the upper part of a leg, whether we are going to see any varicose veins. If there is a varicose veins or the blood supply to the lower part is affected, in that case, we get to see ulceration in the lower part of the leg. Very commonly, you get to see ulcers associated in the lower part of a leg like Raynaud's phenomena and Berger's disease. These are due to lack of circulation. Next is the examination of a nerve. Once the nerve endings to the local area have to be examined, the local nerve supply is intact or not. Because in a tropic ulcers, the nerve supply will be, there will be a change in the nerve supply. Whether the nerve supply is intact or not, we have to examine. Very commonly in the weight-bearing areas like the lower part, a heel of the foot or a ball of a foot, where you will get a sensation loss. Very commonly you get to see ulcers on the foot in a diabetic patient. They will not often notice. We have to examine the diabetic patient. We have to be very careful in a foot ulcer. With this, we'll move on to the classification of oral ulcer. Being a dentist, we get to see a lot and lots of ulceration in the oral cavity, and every book will say a different classifications, and every student have to follow a different classification. Myself in undergraduate level, I found it very difficult to follow what classification. But generally you can say etiology. What is etiology? What is the cause of an ulcer? It can be traumatic. You'll put it as a traumatic ulcer. If it is an infectious ulcer, put it as you can bacterial, viral, fungal. 3 headings. All the infectious ulcers will come in these 3 headings. Next is ask the history, whether they have taken any drugs, whether the drugs have caused this ulcer. Next is whether they are associated with any blood dyscrasiasis, or whether these ulcers are being immune mediated, or whether they are associated with any dermatologic diseases, or whether any gastrointestinal diseases, or it can be a neoplastic ulcer. And last, even we will be in a fix. The ulcers can be due to any unknown etiology. So next is based on the onset of ulcer, that is a single ulcer or a multiple ulcers, a recurrent ulcer, a solitary ulcer, or a multiple ulcer, or a recurrent ulcer. In single ulcers, first comes a traumatic ulcer, tuberculous ulcer, syphilitic ulcer, fungal ulcers like histoplasmosis, blastomycosis, mucormycosis, coccidomycosis. Then we move on to multiple ulcers. In multiple ulcers, we can divide into acute multiple ulcers, chronic multiple ulcers. In acute multiple ulcers, first comes a viral infection, herpes simplex virus. Mainly we get to see HSV1 in the oral cavity above the waist, HSV2 in the oral cavity below the waist. Next is a Coxsackie virus. Next is a varicella zoster, erythema multiforme, contact allergy, oral ulcers due to chemotherapy, and ANEC. That is acute necrotizing ulcerative gingivitis. These all ulcers comes under multiple ulcers due to an acute duration. Next we will move on to multiple ulcers due to chronic duration, like your pemphigus, pemphigoid, and your epithelial bullous dermatosis. Next is recurrent ulcers, chronic recurrent ulcers. We get to see your recurrent aphthous stomatitis, we get Behçet syndrome, recurrent herpes simplex virus, cyclic neutropenia, and chronic idiopathic neutropenia. This comes under recurrent oral ulcers. Next, I will show a flow chart how to go ahead with the single ulcers and how to go ahead with the multiple ulcers. With the single ulcers, we can brief into 4 categories: infectious origin, drug-induced, iatrogenic, and trauma. Any trauma, it's a traumatic ulcer. It's simple. History tells you a diagnosis. Iatrogenic. Iatrogenic is what we induce. A radiation-induced ulcer or any sort of a chemotherapy can induce this ulcer. Next, we'll move on to a drugs. Any drug the patient has taken has caused the ulceration. The last part, which is an infectious ulcer. Infection, we can again think of bacterial, viral, fungal. In bacterial, we get syphilitic ulcer, we get gonorrheal ulcer, we get ANEC, we get tuberculosis. In viral, we get HSV, that's herpes simplex, varicella zoster, Coxsackie, rubella, Epstein-Barr virus. Fungal ulcers, we get to see histoplasmosis, mucormycosis, blastomycosis, cryptococcosis, and coccidomycosis. Next, we will move on to a flowchart of a systematic approach for a recurrent ulcers. A recurrent ulcers, whether it's a patient is repeatedly inducing any trauma, that is due to psychosomatic ulcers, comes under that category, or we have any systemic symptoms associated with the recurrent ulcer. The patient say yes, they have a systemic diseases or not. If there is no systemic disease, then we have to see the location. The location, whether in a oral cavity, whether it's in keratinized mucosa or in a non-keratinized mucosa. If it comes under recurrent ulcer in a non-keratinized mucosa, the diagnosis is going to be easy. It's going to be a aphthous ulcer, that is a RAS, recurrent aphthous stomatitis. It's going to be in a keratinized mucosa like a hard palate or the gingiva. Do a culture for the HSV, that is a herpes simplex virus. If the culture is negative, it can be a atypical RAS or it can be due to HIV or it can be due to cyclic neutropenia. If the systemic symptoms are present, then with a systemic disease, we can think of the inflammatory bowel disease or cyclic neutropenia. In cyclic neutropenia, again you have to think of Behçet's, you have to think of HIV, and you have to think of Sree. With this, we can come to our diagnostic protocol. What is this diagnostic protocol? What all we have seen in this presentation, I am just going to summarize it to achieve the final diagnosis. That is step 1, step 2, step 3, step 4. We can divide into 4 steps. First step, determine whether the ulcer is an acute ulcer or a chronic ulcer. Find out whether it's acute or chronic. What group it falls under. Okay, it falls under acute, then or a chronic. Then go for a single ulcer or a multiple ulcer or a recurrent ulcer. With this brief heading, we can plot this ulcer where it lies in. The next is step 2. Note the feature of the ulcer associated symptoms. What symptoms associated ulcers are. Whether any systemic symptoms are there, we have to think of any systemic diseases. Next, size, shape, location, tissue tax, tenderness, foul smell, bleeding, induration, margin, and a floor. A proper inspection and proper examination of this above point will be giving a valuable clue to the diagnosis. Then next is the presence of any skin lesions. That is your lichen planus, any systemic dermatologic diseases or the underlining. That is a pemphigus, pemphigoid, etc. Next is systemic symptoms like any fever or any malaise has been that is what you call a prodromal symptoms or whether they are associated with these ulcers. The step 3, correlate all the history and the clinical finding and we can come to a differential diagnosis. With the help of differential diagnosis, we can go to a step 4, that is your investigation. We can list out 3-4 diagnoses. With this differential diagnosis, we can go for investigation. With this investigation, will help you to achieve a final diagnosis. Hope I had addressed all the part of the examination of an ulcer. Thank you.